Thank you very much. I would like to continue on now with a technique that I refer to as the flax OVD press. This is a method to avoid femtocapsulotomy tear-outs. Femtosecond cataract surgery has really had very few problems. There are many types of cases like very dense cataracts, white cataracts, pseudoexfoliation, fibrotic anterior capsules, and a few others where femtosecond cataract surgery has really shown itself to be superior to other methods. But a concern since the very early days of femtosecond cataract surgery has been an increased number of capsulotomy tear-outs. These were reported initially in a study by the ASCRS at 10%. And eventually they went down with changes in the femtosecond lasers and a few things to 1.84%. But phacoemulsification currently reports capsulotomy tear-out rates of less than 0.22%, so there's still a difference, and we have to find a way to equalize that. I'd like to first show you a video I found from Uday Devgan, and I'm going to talk to you afterwards why I think this is not an optimal technique to use.
CataractCoach.com, we have an incomplete femtosecond laser capsulotomy, and you can see there's that danger zone where it didn't go through. Now we've done the rhexis with our femtosecond laser. We're going to make the incisions with our traditional blades and diamond keratome. So we've made one paracentesis. I'm going to put trypan blue dye in the eye. It'll help us visualize this a little bit better. And then let's dilute the trypan blue dye with our anesthetic solution, which is lidocaine with epinephrine mixed with balanced salt solution. And now we can see quite clearly that there's still a lot of adhesions of the capsulotomy. It's not a free-floating capsule cutout. So now what should we do? I actually want to make a second paracentesis. And the reason is I want to put viscoelastic in the eye, but I don't want to put viscoelastic underneath that femto-made capsule flap. So there's the second paracentesis. Now I can inject our viscoelastic and push that back down, and we'll get a better view of where we still have capsular adhesion. So there we can see it's those few clock hours. Looks like it's perforated, so it's partial but not complete. We use our diamond keratome to make our incision on the steep axis for the patient. And there's a nice incision there. And now here's the technique using the capsulorhexis forceps. We're going to use the same technique as we do for a capsulorhexis. So we'll grab the tissue here and we'll use a rotational force to separate those pieces. And now we have a complete separation. We still have to be very careful in that one area because it could be weak. Now this is a soft lens on a young patient. We're just going to use the IA probe to remove the entirety of the cataract. So we don't actually need to use the phaco probe. There is no density here. This patient, again, is quite young. You can tell by looking at the eyelashes and the periocular skin that this patient is very youthful. So removing all of the lens material with just the IA probe. Because this patient wasn't in trauma, you've got to be very careful to ensure that there's not a break in the capsule, such as a posterior break. And in this case, everything looks fine. So just take some time here, removing all of the lens material, and then we can finish up the case. So bottom line for today is, be careful with these intumescent white cataracts. Sometimes the femtosecond laser won't do a complete capsulotomy, and that may be because of lens milk that is being expressed blocking the laser beam. CataractCoach.com.
Okay, so thank you, Uday. So the question here is, are there things that could have been done better? Well, firstly, this case was of a young eye and not a usual hypermature cataract that we normally see, so the pressure behind the center of the anterior capsule was not increased. Next, it is best not to irrigate VSS or vision blue into a collapsed eye with a partial capsulotomy, such as he did. The capsule would tend to tear out when you do that. Third, the trypan blue worked because it cross-linked and strengthened the capsule. 4, the second incision and the OVD injection to depress the central capsule, that was actually a very good move. And 5, the method of removing the capsule by pulling it, would tend to tear it if the capsule had a small tear to begin with, because he was pulling anteriorly. If the patient had been older and trypan blue had not strengthened the capsule, it probably would have torn. So I mentioned David Bowie and Freddie Mercury again in Bohemian Rhapsody for us to remember that the original purpose of OVDs was to push back the iris and vitreous to implant an anterior chamber or an iris-supported lens after intracapsular surgery, avoiding corneal touch. So OVDs help us induce pressure in an open eye. If you look at how we do surgery, we all have different styles of surgery that we prefer. Myself, I'm a high-pressure surgeon. I like to use Helan GV, Helan 5, and the very viscous cohesive OVDs, and people like me are sort of very viscous cohesive users. And then there are some that like to use Helan or Visco. That's more of a medium viscosity device, and their surgery is done under lower pressure than I can achieve, but higher pressure than those who use very low pressure surgery with hydroxypropylmethylcelluloses, or some use no OVDs. In both of those cases, you take risks because you can't induce enough pressure in the eye for some aspects of surgery to be safe enough. As I told you in the previous talk, there are many, many steps of cataract surgery which really benefit from having increased pressure in the eye, and for which we want to increase the pressure. One of them I mentioned to you is Argentinian flag sign. And Argentinian flag sign, I told you, is a problem of fundamental rheology. And what I meant by pressure equalized cataract surgery is the following. When we do surgery on an eye, the anterior chamber is always open to allow us to put instruments in it. But in the back of the eye, the muscles aren't paralyzed, and therefore there is, where you see those red arrows, pressure pulling the eye backwards. Well, Newton told us that inside the eye we're going to have equal and opposite pressure, but that pressure is constrained by the presence of the lens in front of the eye. And the transmission of pressure through that lens surface will put pressure on the anterior capsule. In order for us not to have capsular tear-outs, we have to increase the pressure in front of the anterior capsule to equal or exceed the pressure we have behind it. And I refer to that as pressure equalized cataract surgery. So here's a video of doing a patient with a hypermature cataract. And I'm injecting Helan 5 until I see the central part of the capsule become concave. And then I gently paint over trypan blue, but I make sure that I only put a tiny bit so I don't mess up the Helan 5. And then I can do the capsulotomy with a needle because it will not disrupt the incision, and so the Helan 5 will stay in the eye, the center of the capsule will remain concave, and the tear will occur upon the ridge where it changes from being concave to convex. It'll always occur upon that ridge because of the natural pressure and forces induced by the OVD. So, if we look at how we do flax, and we think of it, we can see that it really is pretty much the same as doing a hypermature cataract. It's necrosis of lenticular contents and the imbibition of water that give us the pressure inside the capsule of a hypermature cataract. But in flax, we always find gas inside the lens capsule when we open it. And that laser-induced gas will increase the pressure inside the capsule, very similar to the pressure we have in hypermature cataracts. So we need an approach to do this as well. And so I proposed and just published an article in a Canadian journal on doing a increasing OVD pressure in front of the capsule to prevent capsulotomy tear-outs. And I propose also that the capsulorhexis be done in a Gillesian method. Jim Gills used to always take the capsule and invert it interiorly into the lens, pulling the capsule backwards so that if it tore, it would tend to tear inwards and not outwards, as when you invert the capsule and fold it over on top of the lens. I like to use Haldipurkar masculine forceps, which I'll show you in a video soon. So here's this case, and I'm going to inject Helan GV. I like Helan GV because it has a thin-walled cannula, and I inject that into the eye until I see the center of the capsule become concave. And you can see on the left side of the capsulotomy, the capsule is not separated from the peripheral capsule. These forceps have little tiny teeth on the bottom, and I can take those teeth and depress, pull inwards in a rotational fashion that will pull the capsule away from the peripheral capsule in a rotatory fashion that makes the capsule tear inwards and not outwards. I then take out the capsulotomy and everything is fine. But then sometimes we have a more difficult case, and you can see here that in the image the entire bottom half of the capsule is not free. So what I'm going to do here is the same thing. I use my Helon GV cannula and I inject until I see the center of that capsule become concave. I then will come back with the Hawley Percar Masket forceps, and I'm going to depress in the perimeter where the capsule is not free and pull rotationally, posteriorly, and centrally, making the capsule come away slightly from the peripheral capsule. Once I see the capsulotomy is complete, I will then grab it in the center, move it back and forth to make sure it's free, and then take it out. So this pressure really solves the problem of incomplete caps, and since I started doing this 300 and something femto cases ago, I haven't had a single incomplete capsulotomy, and I've had no problem in doing the surgeries. So in summary, pressure equalized cataract surgery prevents Argentinian flag sign and also prevents incomplete femto capsulotomies in a technique that I refer to as the flax OVD press. Thank you very much. Muito obrigado.